Hello everyone. Today we are going to discuss some important one-liners and MCQs in relation to our most important topic, that is Down syndrome. So to start with, we'll discuss some points about Down syndrome, important points. We can imagine this picture and we are well acquainted with this picture. We know from visual we can know that this is a case of Down syndrome. But what are the important things about Down syndrome? This is the most common chromosomal disorder, also the most common trisomy. The trisomy is here 21, trisomy 21. In 94% cases, the pathogenetic mechanism is your meiotic non-disjunction. 5% cases, it is because of translocation. Translocation can occur between many chromosomes, but most common is between 21 and 14, chromosome number 21 and 14. 1% of cases, the Down syndrome can occur because of your mosaicism. The extra chromosome is mostly from the mother. This is one important MCQ you have to remember. Extra chromosome is mostly from the mother, and maternal age is the most common risk factor. As the maternal age increases, there is more chance of having a Down baby. Usual risk between 15 to 29 years, the risk is 1:1550. But gradually, as the maternal age increases, the risk is also risk to have a Down baby also increases. And by the age of 50 years, the risk would be around 1:50. Next, what do we know about Down syndrome? From that picture, we know many things we can remember about Down syndrome. Most common is your mental retardation, your look is flat facial profile, flat nasal bridge, and off-slanting of eyes, protruded tongue. You can get hypotonia, brachycephaly, clinodactyly, Simeon crease. That is the most important, is single palmar crease. That is called your Simeon crease. Another is your sandal gap. There is a gap between your big toe and second toe. That is called your sandal gap. The associated congenital heart disease, mostly around 40 to 50% cases will get congenital heart disease. Most common congenital heart disease associated with your Down baby is your endocardial cushion defect. This we have to remember. Others we can get VSD, even you can get TOP, you can get osteum primum VSD, osteum secundum type of VSD. But most common congenital heart disease associated with your Down syndrome is ECD or endocardial cushion defect. Other GI features we can get are duodenal atresia. Even we can get head-spring disease. Endocrinologically, you can get hypothyroidism. Your spinal disorder like your atlanto-occipital subluxation is one of the common finding that we can get, though less, around 5 to 10%, but we can get atlanto-occipital subluxation in Down syndrome. There is a thing that there is more chance of AML in a case of Down syndrome. The typical characteristic what we can get in a Down baby during neonatal period, during early infancy, is transient myeloproliferative disorder of infancy. That is one of the common finding specifically associated with your Down syndrome, but it needs no chemotherapy, just needs phototherapy, just needs checkup, because in around 15 to 20% cases we can get in long run AML variety of leukemia in a case of transient myeloproliferative disorder. That is AML M7 type of AML we can get in a case of Down syndrome. Next, these are the things we know, but what are the things we can remember about Down syndrome? What are the things extra? That is your increased Atd angle. This is picture you can remember. This is the A, T and D. This is the junction of the triradius A, B, C, D, and this is the T. So Atd angle, normally this angle is less, around 30, less than 50 degree. But in Down syndrome, because we will get more Atd angle, because this angle will be more. This angle will be more than 50%. We can get it Down babies. This is called increased Atd angle. That is specifically your associated with your Down syndrome. What is that? Another is your Sydney line. What is that Sydney line? This picture we can remember. This is the normal palmar crease. This is the Simeon crease. That distal single palmar crease is your Simeon crease. But if you can get another palmar crease proximal to the Simeon crease, that is proximal transverse crease, that is called Sydney line. This is one thing that we can know about your Down syndrome. Another is your canary crease, that is the crease that we can get in the foot, that is classically associated with your Down syndrome. Next, some important one-liners. Most common genetic cause of mental retardation. Most common genetic cause of mental retardation is your Down syndrome. Second most common genetic cause of mental retardation is Fragile X syndrome. This you have to remember. Most common genetic cause of mental retardation is Down syndrome. Second most common is your Fragile X syndrome. Another confusing, not confusing, but we have to know most common preventable cause of mental retardation, that is your congenital hypothyroidism. So if it is asked if most common preventable cause of mental retardation, the answer is congenital hypothyroidism. Most common genetic cause of mental retardation, the answer is Down syndrome. Second most common genetic cause of mental retardation, the answer is Fragile X syndrome. Second, most common pathogenetic mechanism in Down trisomy 21, that we have discussed. The answer is meiotic dissection. Meiotic non-dissection around 94%, your mosaicism around 1%, your translocation around 5%. The translocation, Robertson translocation, that we can get between the chromosomes 13, 14, 15, 21 and 22. Next, in which form of Down syndrome parental karyotyping is needed? It is not that in all cases of Down syndrome we will send karyotyping of the parents. It is only in case of, the answer is translocation. When you are getting a Down syndrome baby, and if you get the cause of Down syndrome is translocation, in that case we have to do the karyotyping of the parents to determine whether one of the parent is the translocation carrier, which carries high recurrence risk of having another Down baby. Suppose if one parent is having one translocation translocation, then there is more chance of getting another Down syndrome baby. Then next question, which translocation carries 100% recurrence risk? It is not that suppose one parent is having one translocation, then 100% the next baby will be a Down baby. Then the question is, which translocation? If the father is or the mother is having that translocation, then you can tell the parents that your next baby will be a Down baby, so you should not go for another child. The answer is translocation, Robertson translocation between 21 and 22. 20 and 21, that is that is one of the MCQ that we have to remember. For any translocation inherited from mother, the risk of having Down child is around 10%. This you have to remember. But if the father is a carrier, then carrier of a translocation, then risk is around 4 to 5%. If mother is there, translocation carrier, then chance is 10%. If father is a carrier of translocation, then the risk is around 4 to 5% of having another Down baby. But if the translocation is 21, then there is no option. 100% the next fetus, all of the fetus will be a Down baby. Next, which one is not there in the triple test? This we know, but the 4 options: unconjugated hystial, your beta HCG, your PAPPA, pregnancy associated plasma protein A, and your alpha beta protein. Which one is not there in triple test? This we know. This is one simple question. The answer is PAPPA. What is that PAPPA? It is pregnancy associated plasma protein A. Then what are the 3 things we will get in triple test? Unconjugated hystial, your beta HCG, and your alpha beta protein. So now what will happen? Your alpha beta protein will be decreased, your hystial will be decreased, but HCG is increased, H high. This way you can remember, otherwise you will get confused in the exam. HCG contains H, and so high means HCG will be high, others will be low. Then which test is extra in quadruple test beyond triple test? As we know, we are doing triple test, quadruple test, integrated scan in a case of a suspected case of a Down child. Then what is the extra in quadruple test? Is it nuclear translucency? Is it serum inhibin? Is it serum PAPPA? Or it is karyotyping? Which test is extra in your quadruple test? The answer is inhibin. Inhibin will be it is extra in a case of quadruple test. It can detect 80% case of in quadruple test. If you are doing additional test of inhibin, then we can detect 80% case of Down syndrome versus 70% in case of triple test. If you are doing a triple test, then chance of getting a down baby we can suspect around 70% cases. But if you are doing a quadruple test, that then we can get a suspected Down child in around 80% cases. Other tests can be done. What are the tests that can be done in first trimester? These are nuchal translucency, and maternal beta HCG, and your PAPPA. These are things we have to do in the first trimester. Then integrated skin. What do you mean by integrated skin? Integrated skin, this is done in two parts during the first trimester and the second trimester. First trimester, what are the test? It is PAPPA and your nuchal translucency. That is done in your first trimester. Second trimester, your quadruple test, what we have discussed, your HTL, your SCG, your inhibin and FP. All these SSE, all the things you will gather together, then that is called your integrated scan. First trimester PAPPA, PAPPA and nuchal translucency plus second trimester quad scan, that is your combinedly it is called your integrated scan. So what will happen to the level of the maternal PAPPA in a mother carrying a down child? That you can, that triple test, what do we got? We will get only SCG will be high. So what will happen to the PAPA level, PAPPA level, pregnancy acid plasma protein level, it will increase or it will decrease? The answer is it will get a decreased level of PAPPA in a case of down child. Then most common heart disease associated with the Down syndrome, that we have already discussed. Most commonly we will get ECD or endocardial cushion defect. Then other congenital heart disease, what we can get in a case of down child, your osteum primum VHD, even osteum secondum type of VHD, your BHD, even TOF also we can get in a case of down child. Then some points regarding your trisomy 13 or Patau syndrome versus your trisomy 18 or Edwards syndrome. What are the things you can get in trisomy 13 or Patau syndrome? This picture we can remember. This picture, this is a picture where you can get aplasia acuitis, your cleft palate. Some important points we can remember about your Patau syndrome. You can get aplasia acuitis, cleft lip, cleft palate, microcephaly, microphthalmia, holoprosencephaly. That is the most important finding. Holoprosencephaly, congenital heart disease. More you can get in around 80% cases. You will get in Patau syndrome. BHD, PDA, ASD. All these you can get in Patau syndrome. Overlapping of fingers, polydactyly, and capillary hemangioma is the most characteristic finding in a case of Patau syndrome, suspected Patau syndrome. So important, we have to remember polydactyly PPP. Polydactyly, aplasia acuitis, your cleft palate, your holoprosencephaly, and your microphthalmia. These are the important things you can get in Patau syndrome. This is the third most common autosomal trisomy. Most common cardiac heart defect is BHD. Most common cause of death is central apnea. And prognosis very bad. 70% will die in the first 3 months of life. Next about your Edwards syndrome. Edwards syndrome is otherwise known as your trisomy 18. The characteristic is here hypertonia. We have to remember hypertonia, rocker bottom feet. These are the important findings. Other findings you can get limited hip abduction, your overlapping of figures, your hypoplastic nails, micrognathia, seal chest, your short sternum, and congenital heart disease. All these things we can get in Edwards syndrome. But important, what you can get is your rocker bottom feet, your hypertonia. These are the things we have to remember. But Patau syndrome, aplasia acuitis, cleft palate, cleft lip, your holoprosencephaly, polydactyly, overlapping of fingers, all these things we have to remember in the case of Patau syndrome. This is the picture of Edwards syndrome. We can observe the rocker bottom feet and your hypertonia and all these overlapping of fingers. These are things we have to remember. Please like and subscribe to my channel and share this video so that it will be helpful for others. Thank you.